Good morning, Northwest Arkansas. I'm Randy Wilburn, the host of the Onward Ozarks program. Onward Ozarks is a quarterly speaker series created by the council to provide organizations, companies, and individuals a platform to share news, events, and other information with a regional audience. And today, we have a very, very special program. We are doing a COVID-19 physician panel. All the questions that you would ever want to ask about COVID-19 hopefully will be answered today. We are here live at the Mercy Hospital boardroom. They were kind enough to make this boardroom available to us, and we've been able to corral these experts that are around me today to join me. We've got Dr. Michael Bolding from Washington Regional Hospital. We have Dr. David Deschamps from Mercy to my right, Dr. Marty Sharkey to my right, Dr. Sheldon Ricklin to my right, and then to my left we have, bringing up the rear, Dr. Dan Young from Mercy Northwest Health and Washington Regional Medical Center, an infectious disease expert. So, and we also have one other doctor that may join us this morning, and we hope that she'll be able to make it, Dr. Wood. And also we want to just thank Dr. Bhakta for originally agreeing to be with us, but last minute he could not make it. So without further ado, we have assembled a who's who of medical experts here in the region to talk about COVID-19. And our goal today is to address vaccine hesitancy in our community. We want to talk about some of the reasons why people aren't willing to get the vaccine and how we can overcome that. And we also want to talk about some of the milestones in our fight against COVID-19. I know sometimes it doesn't look good because you watch the news and you hear things and you think, oh, the sky is falling. But the reality is that things are improving. And with the booster shot and vaccines, there's a lot of new opportunities. So today, we are going to try to answer all of your questions. I really want to encourage you to get the chat function out. If you have a specific question, we won't be able to get to all of them, but we already have a slate of questions for the experts here, but we will also filter in your questions as well. And if anything surfaces to the top, we will certainly take the time to present that to our experts. So without further ado, I'd like to get started, and I want to kind of lay the foundation for where things are today, October 28th, 2021. There have been 86,000 COVID-19 cases in Northwest Arkansas. That's nearly 16% of the population of our two-county region of Washington and Benton County. Northwest Arkansas is over 53% fully vaccinated in Benton and Washington County. The hope is that we can increase that number based on what we share here today. Benton County is currently at 53.5%, and Washington County is at 54% fully vaccinated. The other thing that we want to mention is that we are, and this is not necessarily a slap on the back, but it is a good piece of statistics, which is that we're one of the among the most highest vaccinated counties in the state of Arkansas. So there is a light at the end of the tunnel there. And then as of yesterday, 745 people are hospitalized in Northwest Arkansas hospitals, 46 COVID-19 patients, and 699 for medical needs other than COVID. And 41 patients are on a ventilator. And we're certainly thinking about them. And hopefully with some of the information that we share today, we will move past this current state of where we are with the hospitalization. So things are improving from where we were at the beginning of the year. But of course, a lot of positive cases have fallen from high water marks. But we still continue to see about 400 new cases each week here in Northwest Arkansas. And I think I personally am saying this as I know my panel would agree, that's 400 too many. So we have to figure out how we can overcome that. The virus is still very much present in our community, and it's still affecting our everyday life. I was just talking about it with somebody before we started recording, how everything changes, how you do things, how you go to the store, how you go take your kids to a soccer game. Sometimes you can't do sleepovers, right? My kids are looking at me like they're crazy because everything is Xbox, Xbox, Xbox. The reality is that life has changed because of COVID-19, and we're going to talk about how we can overcome that. So I want to just take a minute and ask everyone here on the panel to introduce themselves and tell us about the best day that they've had at work since the start of the pandemic in March of 2020. Has there been a good day yet? And I'll start with you.
Dr. Dave Deschamps from the Perinatal Center. I take care of high-risk pregnancies. The specialty is called maternal fetal medicine. And I was gonna say, it just hit me. My best day, and this sounds kind of odd, was delivering a patient with COVID in an ICU who had just gotten a tracheostomy because she'd been intubated for several weeks. But it was the first time I had seen her awake, and she could respond and was able to push and deliver the baby. And the reason I say that was a good day was because that's the only patient that I've had that's lived after having gone to the ICU. That's my one. But she got to see her baby deliver, she got to push, and she was awake for that. And I know that sounds really bad, but that was actually a really amazing thing to be able to see, and that she's getting better now.
Absolutely. Thank you for sharing that, Doctor. Dr. Ricklin?
Good morning. My name is Sheldon Ricklin, family medicine by training. I work with UMS Northwest Campus, but I'm also a primary care physician at Community Clinic in Springdale. My best day so far since the starting of the pandemic, if I really have to think about it, because I work with a lot of Marshallese and Hispanic patients who are at high risk of catching COVID-19. Every time I walk into my exam rooms and actually see them there, knowing that they're at risk, and especially those who were hospitalized from COVID, when they come out, it's great to kind of see them there. So every time I walk into an exam room and I see my patients there, that's a good day for me.
Okay, thank you for that. Dr. Sharkey?
Yes, my name is Dr. Marty Sharkey. I'm a pediatrician by training, and I am the Fayetteville City Health Officer. And this question's an easy one for me. It's February 26th. That is the day that we did the big mass vaccination clinic at J.B. Hunt that the Northwest Arkansas Council sponsored. And we vaccinated thousands of elderly patients that day. In a day not unlike today. It was cold, it was rainy, and we were out there all day vaccinating thousands of patients. And it was the first time I saw a light that we were going to come out of this. And it was also the first day for me that I felt like the Northwest Arkansas healthcare community was together as a team. And it was fantastic. We were, all of us that were out there working that clinic, were on a high by the end of the day.
That's awesome. Yes, sir, Doctor.
Good morning, I'm Dr. Mike Bolding. I'm a hospitalist at Washington Regional Medical Center in Fayetteville. I heard a good sermon a month or so ago about you don't know what a good day looks like until you've had a bad day. And that's what those bad days are for, is to know what a good day is, to compare and contrast. And so if you've done what I've been doing for the last 19 months and 9 days, but who's counting, right? And seeing these patients that end up on ventilators and have been in the hospital for weeks and weeks, and many of them don't survive their hospitalization, and you're calling families and you're getting very close with the families, and seeing those patients not survive their stay certainly lets you know what a good day looks like when you get to walk into a patient's room and see the face light up, to know that it's the day that they get to go home. And for whatever reason, that they survived their hospital stay where others didn't. And you get to call that family and say, you know, your loved one is going to get out of the hospital today. And we celebrate those days. So I will remember every one of those. So there's been some good days.
Good. That's awesome. Dr. Young?
All right, I'm Dr. Daniel Young. I do infectious disease out of, we serve all the hospitals and do consults in Northwest Arkansas. And I think my best day is today because I get to hang out with these guys, and I think the only day better than that's going to be tomorrow. And the reason is because we really know we can do this.
Dr. Wood, welcome.
Thank you. My name is Dr. Amanda Wood. I am a family medicine OB physician. So I take care of, primarily in my practice, young families, women, children, pediatrics and obstetrics. And so I have seen people all across the spectrum, from new babies to older adults who have had COVID and who've dealt with it. And I have conversations in my practice, you know, half a dozen every single day about vaccines, about the virus. And it has been definitely very challenging. Probably my my best day, aside from the vaginal twin delivery that I had a few months ago, which is always pretty special, was I had a woman in her, I would say in her early 60s, who came in and she was, I'm not getting the vaccine, I've heard all of these terrible things, and we sat down and I said, well, why? You know, just tell me a little bit more about what you understand about this. And we walked through a lot of questions and misconceptions, and she realized that she had been taking in a lot of myths and a lot of negative information from social media and family members, and she left my clinic with the vaccine that day. And so that was probably one of my best, most encouraging days.
Yeah, a win is a win is a win. That's good. Well, thank you all for all sharing very poignant moments in your experiences over the last 19 months. It certainly is. I think we always have to look at the fleece and the lining that shows that there is hope and there is light at the end of the tunnel for this COVID-19 pandemic that we're all dealing with. It's not just the folks that are out there watching this. Even these doctors, they all have families, they all have loved ones, so they're as affected by it as you all are watching this today. And so what we want to do is we want to take some time to go through a number of questions that we know a lot of you have. We want to dispel, like Dr. Wood said, a lot of the myths and rumors and fake news that's out there so that we can really get to the bottom of this whole pandemic and understand exactly what COVID-19 is. So I want to start out with Dr. Young. And I want to talk, Dr. Young, with you about how has COVID-19 impacted our community here locally? Because we realize that COVID-19 is affecting different communities around our country differently. So I would love for you to share, how has COVID-19 impacted our community locally? What has improved, and what do you see that are still some of the biggest challenges that exist?
Yeah, so in Arkansas, there have been probably 510,000 total cases and 8,300 deaths. In Washington County, we've had 480 deaths, and I think Benton County, 601 deaths. And so obviously the number one impact is going to be morbidity and mortality. So we've had a lot of people dying, a lot of people losing loved ones, family members. Also just stressed out to the max, absolutely full hospitals with stressed out staff, hospitals at capacity, economic impact on the communities, people losing their jobs, businesses closing because of the economic stress, and then just stress on a personal level for mental stress, physical stress on the people that work in the hospitals and take care of all the sick people. So that's probably the biggest impact on the community that I've seen. As far as what's improved, we kind of hit this really bad peak in early August, and over the past 30 days since August, we've had kind of a downward trend in cases, so that we've seen for the first time since that time less than 100,000 new cases a day in the United States. And there's kind of been this 2-month rise, 2-month fall, and a lot of that is because of behavioral changes, so things we know that we need to do to help stop the spread of the virus and vaccination. And so that tells me that what's improved is we know we've got something that works. We know what we need to do to get this thing to go back down. And working together, we can do that thing. So if people get vaccinated and people do the things that we know we need to do to get the spread down, we can overcome this thing. And so challenges, remaining unvaccinated or remaining non-immune, we'll say, will put the community at risk for continued spread of the virus. And so as we see people starting to let their guard down and get back together, as they remain non-immune, this virus is not gone. It's just not spreading as much right now. But as we get back together, especially for the holidays, we're concerned that we're going to see another spike, and that's because of people remaining non-immune. And so also, if you're in contact with somebody that's sick, and if spread in the community is high, we have to go back to doing things we know, masking up, social distancing, things like that. We have data now. The CDC's allowed us to look at data that shows deaths and cases by vaccination rate. We know, and we've suspected this, but we know that vaccination will help you stay out of the hospital. It'll keep you from getting severe disease and prevent death. And kind of just what we've been seeing in the hospital, guys, If you're vaccinated, you are almost certainly not going to end up in the hospital or with severe disease, with some exceptions like really profound immunosuppression. And the biggest challenge, I think, though, is there's this misconception, this crazy notion that we're going to be able to just kind of hang back and wait this thing out. That is not going to be the case. So this virus is with us and maybe, unfortunately, maybe here to stay, maybe here forever. So we're not going to be able to hide out and just wait this thing out, remaining non-immune.
Okay, Dr. Young, I appreciate that. I want to follow up with some of you, the other doctors on the panel, to ask specifically, because I know people think about this. It's like, well, I may not get COVID, or I don't know anybody that's gotten COVID-19, but even if I do, it may not be that bad. What are some of the short and long-term risks of having COVID-19? Who would like to answer that?
So you mean a short term? So it's in the short term, people can get sick and they can miss school and work.
Right.
Long term, people can get really sick and they can end up in the hospital on the ventilator with respiratory failure, multiple organ failure, and end up losing their lives. And I think statistically, if you get admitted to the hospital with severe COVID, you probably have about at least a 10% chance of dying in the hospital. So that's short term. Long term, we're seeing kind of some weird stuff. We're calling it post-COVID conditions. And again, as Dr. Bolding said, we're in this thing 19 months, so we really don't know how that's going to play out long term. But there are people that are having late complications of COVID, people that are more severe long-term respiratory issues like chronic shortness of breath, cough, heart disease. So people have gotten out of the hospital with permanent cardiac damage. There was a study that showed that if you get admitted with COVID, you have a more than 50% chance of coming out of that admission with cardiac permanent damage. And then there's, with more severe disease, there's long-term autoimmune things people get where your immune system attacks the healthy cells of your body. So people are coming out with chronic kidney, liver disease, skin diseases, this brain fog thing. So there's a lot of long-term post-COVID things that we haven't really fully fleshed out yet, but that do exist.
And what in layman's terms, what I hear you saying is that there's a lot of us walking around with either undiagnosed issues that become exacerbated because of COVID-19, or just are able to maintain. Like I have asthma, and I've been told that, man, with asthma and COVID, it's not a good combination. And there's a lot of people that have asthma.
That's right.
So that can impact them very, very severely.
Yeah, I see people now, 6 months, a year out from their initial infection who were previously healthy. I have a young guy in his 30s who was, a healthy dad of two, had no issues health-wise, and now is on oxygen long-term and has a lot of complications just in his day-to-day life because of the long COVID syndrome that we're seeing. I have patients who were previously healthy and the virus attacked their thyroid and now are on thyroid medicine, possibly permanently, 6 months out from having the virus. And we see long-term effects in kids too. From a pediatric perspective, kids who are not just dealing with fatigue, but a lot of concern in the news about the myocarditis, pericarditis, and there's been a lot of question, the vaccine's going to give my kids this, but in reality, the numbers that we've seen from the virus actually giving this long-term side effect to kids has been astronomically higher.
Right, yeah. And we're gonna spend a little bit more time talking about, especially ages 5 to 11, the vaccine that's been developed, and I guess we're in the process of being approved by the FDA. I did want to ask you guys this one other question, because this is something that I know a lot of people struggle with, is where do we go to get the right information? There's a lot of information being shared about COVID-19 on various channels, TV, social media, Facebook, you name it. How do people know who to trust? And in your estimation, what is real and what is not?
I think there's just so much bad, misleading information out there on TV and social media. And this is not the thing that people have trouble understanding, because this is the same process that we've used for decades and maybe 100 years. There's a scientific process of where we used evidence-based medicine. We look for real expert opinion, people that actually practice the medicine, look at the research, and we use real-life data to come up with solutions to these problems. And that's no different with COVID than it was with any other thing we've ever done. And so I think, and I understand 100%, I get that Americans, they don't like being told what to do. We don't like, I'm the same way. We don't like authority, we like conspiracy theory, but the reality of it is there is no conspiracy theory with this thing. This thing is real life, it's here, and we are trying as a medical community to take the knowledge that we have gained and bring to bear against this virus. And so what I tell people is, trust the same people we've trusted for decades. There are institutions that have been serving the U.S. and the world for decades. The CDC, the National Institute of Health, the World Health Organization, the IDSA, and just especially even more importantly, your local healthcare community. We're treating this no differently than we've treated any other thing in the past decades. And I think the social media, bad information on TV has really thrown a real wrench in there as far as creating a lot of confusion, misinformation.
Yeah, it has. Dr. Sharkey, how have you overcome that?
It's been a challenge in my role, but really relying on, like Dr. Young said, the reliable sources. We need to go with our experts. One thing that's been really challenging is the publication of preprint articles online, and people are hungry, desperate for information, and they're looking at those, and a lot of them unfortunately have some bad science and get pulled down 2 weeks later, 2 hours later after somebody's seen it. But once you see it, you can't unsee it. So we really look at what we call the body of evidence. We don't make decisions based off one study. So for that reason, it just takes a lot of very smart people in deep, dark discussions sometimes going through this information and coming to the best conclusions. And it's all trying to get us through this as healthy as possible. So looking at the CDC, the FDA, the World Health Organization is really what we've got to rely on.
And I know somebody's probably watching this and saying in the back of their mind, but I got this information from a doctor. Mm-hmm. How do you deal with that?
I would like to answer that. So if your doctor is actively seeing COVID patients dying from this virus and all the effects that this virus does to actual humans, listen to those people. And if your doctor may have had a political slant pre-COVID, they probably have one currently during this pandemic. And that's the unfortunate part of this is the people that claim to be on front lines that maybe aren't. Look to see if that person is telling you some information while also trying to sell you a product. I would look for that. If that doctor is actually seeing COVID patients and has no other agenda other than to end this pandemic, which is this panel up here, I would trust those people. But we fight that all the time. I agree. That is very frustrating when people say, my doctor is telling me this, and 99, I would say probably 100% of the time, their doctor is someone that's not actively seeing COVID patients in COVID ICUs and in the hospital.
Or maybe has a loose application of the Hippocratic Oath too, so there's that.
And I'll add, the American Board of Obstetricians and Gynecologists actually sent an email out that said, if it is found that there is a physician, an OBGYN, who is board certified that has been telling patients that it is unsafe to get a vaccine, their board certification is on the line because the science, evidence-based science, does not support that at all. And in fact, that could be responsible for patients' deaths, fetal or maternal. I mean, I've seen that, and so you need. I agree with Dr. Boulding where you need to kind of look at what's the motivation behind the message that's given to you. Why would somebody tell you not to do something when almost 9 times out of 10 you're not going to hear that opinion from somebody else? And I'll tell you this, everyone is afraid of the virus, and it's okay to be afraid of the vaccine and all of that. That's okay. It's natural fear to be afraid of those things. But a lot of what you'll hear will be smart people know you can play on people's fears, and people are looking for a reason to validate their fear. And that's very hard to overcome. It's harder to be courageous and do the right thing when it's kind of unknown. But I would say at this point, a lot of this is not unknown anymore. And so if there's still somebody telling you something that seems maybe wrong, and even now you've seen, whether you've seen people die or not, you are starting to, everyone now knows somebody that has died or been affected by this. And I think that's why vaccination rates are going up. But I think you look at the motivation behind why that message is being told to you. Yeah. I also, just as an anecdotally, an email first came out, you would get all sorts of, there's a whole junk email folder, right? And you can forward that stuff there. You don't really have that on Facebook or Twitter. So if something pops up and you see it and you're like, oh, this is fascinating, be like, why did that pop up? And would this have gone to my junk mail like back in the day when when I'd get a whole bunch of weird junk mail from friends that didn't know they were sending on chain letters? I mean, that's a lot of what this stuff is on Facebook. So just because it's on Facebook doesn't mean it's not the same as like junk mail in your mailbox.
Absolutely.
It's the same thing. It's just put out there, and people that grab onto it will grab onto it, and the people sending it know that.
It is called spam for a reason.
It's spam. But we don't have a spam filter on Facebook.
We don't.
You're exactly right.
Yeah, absolutely. Well, I want to move on, and in this same vein that we were talking about in terms about how do people know who to trust. Dr. Ricklin, I want to address this with you. The speed of the vaccine development. I know when I heard all the stories about, oh my God, it takes 5 to 10 years to develop a vaccine, and we did this in light speed. And I have to believe that sometimes when you're faced with great adversity, you rise to the occasion. And I feel like that's what the medical community has done, what vaccine development has done. But I would love for you to share, how have you been answering that question, especially in the Marshallese and Latinx community that you serve in Springdale? Because I'm sure it's come up. How have you been dealing with it?
No, absolutely, and that's a great question. And I do have, dealt with it with the Marshallese and the Latinx community. And just like, the other colleagues on the panel, when you talk with your patients of the vaccines, it's always important to listen to the concerns. Okay, I think many times, people come with different ideas. There are some who are on the fence, and they just need that reassurance from their primary care physician or their trusted friend, the trusted messenger, to say, yes, it's okay, go ahead and take it. But there's others who have other things that they've heard on social media and in public that are myths and disinformation, and they just need that answering of those questions. And of course, the speed of the vaccine definitely is one of those things that people are concerned about. Is it safe? It was too fast. But if you look back to last year, when we didn't have any vaccines, that's what we were trying to respond to, right? I think, when the disease came in December of 2019, many of us, including myself, I had to learn what to do, right? It was basically, I thought I was in medical school again, right? But I took learn medical school things in real life to try to respond to that. So that was definitely in response to that, because we definitely needed something to combat the pandemic. The global pandemic, that was a public health emergency that started last year. So definitely it was quick, it was fast, but the process, the safety measures that the FDA and CDC followed in making the vaccines were not compromised. So the FDA definitely is keen on making sure that the development of vaccines are safe, they're effective, and they can be used for people, and most of them usually would get better with the vaccines. And we know this because the history of vaccinations and immunizations in this country and the world actually has helped take away some of the bad chronic infectious diseases that we've had in the past. So we don't have to deal with the polio, okay? We don't have to deal with measles, right? And we have to, there's some dealing with some of the influenza and all those other things. So yes, it was quick, but the science and the safety measures were still there. So it definitely is still safe with the vaccines.
Yes.
Just to look at the mRNA vaccine, scientifically speaking, interestingly, and you kind of have to look at how money is allocated to develop vaccines. So generally, infectious disease vaccines are a public health expenditure. There's not a ton of money going into it. not a lot of private money or insurance money going into that. But that's because it's for the benefit of us. It's a public health thing that we benefit from. But it's also hard to pay for new vaccines. There's not a lot of new vaccines that get developed. But mRNA vaccines come from the cancer world. So tumors, there are certain proteins on tumor cells that you can make an mRNA for and give to a patient with that tumor and allow their body to make an antibody to that tumor and kill that tumor. So if anybody that's watching this has ever heard of anybody getting immunotherapy for their cancer, that is actually essentially an mRNA vaccine. So for about 5 or 10 years, and the reason why the FDA approved it so quickly was the safety data on mRNA vaccines has been around for a very long time. The companies did not have to go through the phase 1, phase 2, they didn't have to, it was expedited. The question was, does the mRNA that they use for the spike protein, which is the same process they do for tumors for patients, takes them about 30 days to develop a vaccine for an individual patient. They did the same thing they've done for years just for coronavirus. Well, why? Well, because all of a sudden there was money available for that, and that, obviously it's a very expensive undertaking, but it's also was very successful. But the safety of the vaccines have been used in the cancer world, these very same vaccines, actually for some time now, and that's why the FDA was able to approve it faster.
Yeah. Yeah, and it is hard. The thing I always, as I'm not a doctor and I don't play one on TV, but I think that the reality is that I've had family members that have died of cancer, and I remember them thinking or considering taking experimental drugs.
Right.
They weren't sure that they were fully vetted or they will do it. Some of them help them live a little bit longer, and people have been with different illnesses have been willing to take experiments. And it's almost like it's been harder for people to take the mental leap with COVID-19 to say, you know what, this might be experimental, but if it saves my life, I should maybe consider it.
So I will have pregnant patients ask me this very question, and I will treat patients with breast cancer or cervical cancer that are pregnant. There are chemotherapy regimens that are safe in pregnancy. Safe, yeah, I mean they are, but that is extremely more toxic to you than the COVID vaccine would be. You would definitely not turn down chemotherapy if it was going to save you so you could be a parent to your child. I mean, that's how you think, So why would you turn down a vaccine that has proven efficacy and actually has been used to treat cancer patients before and avoids the toxicity of chemotherapy in those patients?
Yeah.
That's exactly where this vaccine kind of comes from. When people think about that, they're kind of like, oh, well, that makes a lot more sense because I'm really not harming my baby, but it's not like I would forego chemotherapy that was safe, and this is safer than that. I mean, to put it into perspective, and sometimes you just need that relativity to reason through it and be like, oh, that makes more sense,
right.
Because it's not as unknown as we think it is, and it's not nearly as unsafe as we think it is.
Yeah, and that's why I think these conversations are helpful, because people are listening to what you're saying, and now they're maybe having an aha moment that, okay, maybe this isn't as bad as I thought it was.
Correct.
So,
yeah.
Would anybody else like to weigh in on this, Dr. Wood or anyone?
I definitely agree with that these vaccines, from what we're seeing, are incredibly safe. And I treat kids, I treat pregnant women, I treat older adults, and I'm a mom myself. I have a 7-year-old and a 10-year-old, and I'm itching for the vaccine to be approved because it's a layer of protection for them, just like I send them in a mask to school every day, just like I got their childhood vaccines when they were growing through all of those ages and stages, because I didn't want them to get varicella, because I didn't want them to get the measles, because I didn't want them to get all of those things, and because I wanted to protect the community around them as well and prevent my kids, myself from spreading those different illnesses. It's what we see with this vaccine, that the data is there, and we've had the data around for a long time. And that's labor and delivery, so I'm sorry.
Duty always calls, so no, I appreciate that. Thank you.
Excuse me one second.
Yeah, sure. Let's go ahead and piggyback on what we just talked about in terms of the whole process of going through the vaccine. Dr. Boulding, I would love to get your thoughts about side effects and safety of the vaccine. So what are some of the side effects you're seeing with the vaccines, and are there any themes with the types of people that are being impacted by it?
Sure.
We could quote like the VAERS data and the percentages and all that, but it seems right now that anecdotal stories are kind of hit home a little bit more. And so the vaccine has been out. We started vaccinating healthcare workers and those at risk December of last year. And I've been in the COVID unit more days than not for these last time frame, for the last 19 months, and certainly for the last year since the vaccine's been out. I've admitted one patient to the hospital, early 20s gentleman who had myocarditis. He was doing his on his laptop, he was doing his college classwork. The next day was pain-free. He had no structural heart damage whatsoever. That was about 48 hours after he got his vaccine. And that's what we've seen across the board, where the myocarditis, pericarditis risk is certainly there with the vaccine, as it is with other vaccines that we've seen. Certainly one patient that I've admitted, and at our hospital we've seen maybe a handful total that even we thought maybe that could be vaccine related. I mean, kind of their platelets dropped within a few days of their vaccine. No mortalities that we think are related to the vaccine whatsoever. And so you compare and contrast that with what we've seen with what COVID does.
Sure.
Everything we do in medicine has somewhat of a risk. You put someone on antibiotics for a bacterial infection. We treat people with cancer with chemotherapy. We know that those things cause some harm in some cases, and they have their own risk and side effects. But we always weigh that risk. And so just like we talked about with cancer, my dad had stage 4 pancreatic cancer. At no point did we say, what is the major side effects? I mean, we asked about side effects about chemotherapy and certain things that could treat his cancer, but certainly we know what happens if you do nothing.
Yeah.
And so I think one thing we've talked about is experience changes behavior. As we think about what changes folks' behavior and opinion on the vaccine, well, if you've had the experience that some of us have had with what this virus is capable of, that would change an opinion on what minimal side effects a vaccine has to your personal health versus you're walking along 30, 40 years old, got your whole life ahead of you, you contract this virus unvaccinated, and you may not make it out of the hospital. And we're seeing that with the virus. We're not seeing that with the vaccine. So your risk-benefit ratio is overwhelmingly on the side of protecting yourself with the vaccine. And you think about the safety, short-term safety. You think about the millions of doses that we've given between the 3 vaccines. Think about the Johnson & Johnson pause that happened. That paused. We stopped giving the Johnson & Johnson vaccine for literally 6 to 12 cases of a cerebral venous thrombosis. 6 to 12 cases out of millions of vaccine given. That is how close this thing is being monitored. People saw that and said, wait, this is out of the range of normal for this condition that's happening at an increased rate. It's in childbearing females. Let's wait, let's look at this data. Even after that was looked at, they still came out to say the risk of getting COVID and what it can do to you is still worse than the 6 to 12 out of a million that could get this condition, which is much more treatable for the most part if you catch it early. So the safety data is there and is ongoing, and we're still watching this.
Has anyone died from receiving a COVID-19 vaccine that you're aware of?
Not that I'm aware of.
Okay.
Certainly not at our hospital. I would say Mercy would say the same thing.
Okay.
I've got something to add to that too. That
Sure.
If you look at the VAERS is just a reporting system. So if I get their deaths reported on VAERS, but the problem is none of them have had any causal link to the vaccine. If Dr. Bolding gives me a vaccine and I walk outside and get hit by a truck and die, that might get reported as a vaccine-associated death. So when they've looked at these reported deaths, they have found no causal link at all to any deaths actually associated with the vaccine.
Okay.
That's why you can say that hasn't been caused by it. None of the deaths have been caused by the vaccine. I think another important part is, myocarditis. One of the biggest studies came out of, California, kind of just looking at this, and then you have to look at looking at ED visits for myocarditis. They happen whether you've been vaccinated or not. It's not like myocarditis is a super rare event. It happens with lots of viruses. And they're much worse than this kind of transient myocarditis, which has happened in oddly young men. But they've all, no one, in this study, no one was ever in the hospital for more than 48 hours. No one ever received oxygen, and they were like literally watched and then went home. So you kind of have to look at the VAERS data with a grain of salt. It is a reporting system that has no underlying science. It's just this patient got a vaccine, and in a month later, X things happened in their life. You know, they got a divorce. Okay, but that was not caused by the vaccine. They died. That may have not been because they got it. You see, there's no causation or link to say the vaccine caused any of those events. But it gives, what it does is it gives the CDC and people looking at it a reason to go study a possible link. You see a spike, you're like, ooh, okay, let's go look for a link. And a lot of times you don't find a link, most of the time. Sometimes you do, those will bear out, but.
Yeah, and I'm sure Dr. Deschamps would agree in caring for pregnant women. When we look at the studies, we have compared the pre-vaccine, pre-pandemic complications, preterm birth, miscarriage, those kinds of issues with what we're seeing now, and there's no difference. So though all of those things happened before we had COVID even around, even existing, and the numbers are not any different. What we're seeing right now.
There's a baseline rate for all of these things in the population, especially in obstetrics. Preterm labor happens, stillbirth unfortunately happens, but the rate is no higher with vaccinated individuals. I will tell you that those rates are higher in patients that do get infected.
Mm-hmm. Yeah, 70% higher ICU.
I was going to talk about Delta variant later, but it is a different beast.
Yeah.
If only we still had Alpha variant as far as pregnancy goes, it would be so much better.
Yeah.
I also like to address long-term effects of vaccines. There's a lot of discussion about that. We have not seen any long-term side effects from the vaccine, from the COVID vaccine, or any vaccine ever. The side effects that we see are acute within the first few days, maybe the first couple of weeks, and that's it. So we do not expect, of course, we're watching to make sure that there's no long-term effects from the COVID vaccine, but we have not seen any to date, nor have we seen any long-term effects from any vaccine ever. So it's important to note.
Okay. I appreciate that. So I do have one question in the chat. I want to encourage anybody watching, if you have a question, remember, the only dumb question is the one you don't ask. So please ask a question. But this is a highly technical one, and I think I know what the layman's version of this is, but you can correct me if I'm wrong. But here's the question. How are the antibodies to the S1 spike protein in the vaccine superior to antibodies produced when encountering the wild virus, which produces antibodies to the spike protein, envelope protein, nucleocapsid, and membrane protein? I'm glad I did take some biology classes. So. But I think, are they asking essentially, how are the antibodies that are developed through the spike protein in the vaccine, if you actually take the vaccine, how would that compare to you just getting COVID on your own and fighting the good fight and trying to push through? Yeah,
the thing about it is we're going to know all this stuff in about 30 years. Okay, but the thing so there's questions. There's a question in a notion and a thought that if you've been infected, you don't need the vaccine. Well, the problem is Delta variant is a completely different virus than wild type and Alpha and Mu and any of the other variants. So the problem is people are getting Delta variant despite having history of being infected with the wild type variant, which was the original. Now we don't know, and this is their studies right now, having natural antibodies to Delta may be really, really good about preventing Delta. But we just don't know that, and what we do know is just look through the hospitals. We don't have data about people previously being infected staying home. All we know is people that are immunized are not in the hospital. So that's all we know. So we don't know this far ahead what those natural antibodies, what role they play in protection, and certainly that the problem is when you have a variant, all RNA viruses, the reason they mutate is because if I write you guys a letter, I'm going to spell check it. Viruses cannot spell check. So when they replicate, they make errors, and those errors make more errors. And some of the errors will fade a virus out into oblivion. They'll be less fit. But some of them, like Delta, are stickier. They make you sicker. They replicate faster. They are immune evasive. And they're really, really superior to the original. That's why they get selected out. And then the other antibodies that would bind up the spike protein won't bind as well to the spike protein of Delta. Even the vaccine won't. Now, and we know that because people are getting breakthrough infections and still getting infected with Delta despite being vaccinated, but they're not going into the hospital. So despite the fact that you might still get infected with Delta variant vaccinated, your chances of going into the hospital and dying are extremely, extremely low. In fact, I can't think of any immunocompetent, like a normal immune system person I've seen that has died of COVID in the hospital. The ones we see are profoundly immunosuppressed, like a solid organ transplant recipient, or somebody that we know now needs maybe more vaccine or don't respond normally to vaccine. So that we just don't know. All we know now is if you're vaccinated, you're not going to end up in the hospital. So we don't know how those natural antibodies play out compared to vaccines. We'll probably know in about 20 or 30 years.
We do know that the natural antibodies also don't last as long. Their staying power, we know after 90 days you are at risk for getting infected again. Yeah. Even with the same virus, and that's kind of what we learned by the spring, which is when we started saying you should get a vaccine if you've been infected, because we were seeing reinfection. So, and that's kind of the problem with coronavirus. There are certain things that our bodies will make an immune response to, and we will keep making those antibodies for years. Coronaviruses are a little bit like a rhinovirus. You get a cold that year, you may not get that cold the rest of that year, but next year when the new virus comes around, your antibodies are gone. Your body's like, eh. So our body treats the coronavirus antibodies that same way. We get a nice spike, but then we just kind of lose them because coronaviruses have never really killed us before. Not like this. And so the immune response you get from the mRNA vaccines is at least 9 months, if not longer. It's a more generic response, but it covers everything better, not as specifically. I will say there was a report in one of the Nature journals where patients that have actually gotten infected and then had a vaccine actually had some super responses. In fact, better than anybody that hadn't. That's not to say please get COVID and then get a vaccine. That's not what I'm saying at all. But what I'm saying is, and I've had patients that are like, in pregnancy, I got sick. I thought that scared the heck out of me. Do I need to get the vaccine? Yes. And in fact, you may respond better than anybody else that, like me, that have never had COVID that I know of and then got the vaccine. Yeah. So it's a very good question. I mean, that's a very good question. And yes, you will make a very good antibody response, but it is not lasting. And it may only be specific. It may be too specific. You actually want a more generic antibody that will attack a new virus and not let it take hold. And that's what the vaccines allow you to do. So you should get it after you've been infected, and you may actually be better off.
And you don't have to wait months to do that.
No, you don't need to wait a certain amount of time.
From your quarantine or isolation period, depending upon where you are, you can go get vaccinated.
Right
away.
Yep.
And I'm sure there's a vaccination site very close to where you are that you can take advantage of. And trust me when I say this, there are all kinds of opportunities for you to get vaccinated, and that's something that we really want to encourage you to do. And maybe after you've experienced this amazing panel here today, that would be enough information for you to move the needle forward. I do have a question for you, Dr. Deschamps, as well as Dr. Wood, since this is around pregnancy and fertility, because I know that there are women thinking about this. Is there anything around the long-term effects that could impact fertility if a female takes the COVID vaccination?
Correct, and there's a couple things to that. So no, it does not. Several studies, it has not affected fertility. It does not affect miscarriage rates either, which is early pregnancy loss. In fact, the original, the early VSafe data, which was coming from the CDC in pregnancy specifically, showed that vaccinated individuals actually had a lower miscarriage rate or early first trimester loss. But as far as fertility, no, it does not affect your fertility rates. It does not affect your ability to get pregnant or ovulate or achieve a pregnancy.
Okay, all right.
That's, I mean, at the end of the day, whether getting infected or not, or having the vaccine, that does not affect your rates.
So it's not too late for someone who's currently pregnant to get the COVID vaccine.
You should absolutely get it.
Right.
Today.
So, yeah. Right. Any other anecdotal stories that either of you would like to share about some of your patients that were maybe on the fence, but ultimately when you convinced them and things worked out? Because we've had 19 months of.
Yeah, I will say that early on I had a lot of patients that were in healthcare settings that were definitely wanting to get it, but again, the problem was they didn't understand what an mRNA vaccine is. And I really started giving this kind of talk about the history of vaccines. And we were talking about this before the panel. There's the oral polio vaccine. I mean, we used to give you, and still do in some vaccines, we actually give you the virus. It's an inactive virus, but you're getting infected. And then we moved to the harmless adenovirus carriers. So they carry the protein that you want to make an antibody response to, but to get it in there, we have to give you this adenovirus, which is harmless. But this is even less harmful, and this is what's important for pregnant patients to understand is you literally get some like water and mRNA, which are just nucleotides. They're just little teeny chemical proteins that make up a computer code, so to speak, to make something happen. Your deltoid muscles make the protein. Give it to your immune system. Your immune system's like, awesome, I have no idea what this is, but I'm going to make a whole bunch of antibodies. Within hours, it's gone. Your body breaks those nucleotides down and reuses it for its own mRNA. It's like, hey, you gave me some nucleotides. I can reuse this after I make this protein. So you're not getting infected with any virus, not even a harmless virus. The mRNA never even enters your bloodstream. It never leaves your deltoid muscle cells, really. But those antibodies, that antibody response will cross into your placenta and into your baby. Babies are born with it in the cord blood, so we know they're protected, which is the whole point of getting the Tdap vaccine during pregnancy. So your baby won't get pertussis when it comes out. Because who knows, at church or in your family who hasn't had the pertussis vaccine may have pertussis, which is one of the breakthrough ones we can see. We do that because the breast milk and the baby will get those immunoglobulins from you to protect them. So you're protecting your baby, you're protecting yourself, and there's only a benefit. And the vaccine, your baby had no idea you got it.
Yeah.
It just doesn't, yeah.
Well, I appreciate that. I'm glad that you guys had a chance to kind of tease that out a little bit. We're going to land this plane in a few minutes. I did have another question that came up, and then I want to jump right into talking about the vaccine for children ages 5 to 11, which I know a lot of people have concerns about. It seems, this is the question, those who get sick are told to stay home and hydrate until they get so bad they need hospital care. What recommendations do you have for those folks to treat at home or to prevent if they don't get the vaccine for whatever reason? How do we self-care as far as that's concerned if they don't actually get the vaccine?
Well, there's the monoclonal antibody crowd where you have the asymptomatic, not going to the hospital, not getting sick, but it's within a few days of getting the virus. There are monoclonal antibody treatments, infusions that can help prevent severe disease if you've not been vaccinated. And even in pregnancy, we've been using that as well. That's an interesting one because we think about treating people that are really sick, using remdesivir in the hospital, and there's monoclonal antibodies you can use in the hospital. But there is an antibody treatment that you can give a patient before they ever end up in the hospital. Mm-hmm. Then they go home and then they wait, but it helps decrease their risk of needing to show back up to the hospital while they're waiting.
So there is still something they need to
There is a treatment, yeah, okay. And your doctor, if your doctor's office knows and the timing is right, you would be a candidate for that.
Okay.
One of the big problems is we really just don't have, the bottom line, we really don't have any great treatment. There's no silver bullet, and so as you look through all the things, there are things we thought might work that really turned out to either not work and cause harm, like hydroxychloroquine. If you go into the hospital even, there's really not a lot of treatment available. You can use some steroids. There are all these crazy, really long, hard to pronounce drugs that can help reduce inflammation that we would give for rheumatoid arthritis back in the day. And then there's remdesivir, which is an antiviral created for Ebola in 2014 that we got really excited about. And when it came out, we're like, it really doesn't even improve mortality at all. It may reduce your hospital stay. So we really don't have any drugs at all really that are silver bullets to treat this thing. And then to more unusual things, there's a ivermectin hype right now, and of course we know that has no benefit at all. That's an antiparasitic that in test tubes can have some antiviral property, but the amount that you would need to treat a human for COVID is astronomical. And what we've seen with ivermectin is confusion, people still getting admitted on ivermectin, and people getting toxic. I think there was 1 week where 70% of the poison control call centers in the state of Mississippi were related to ivermectin dose. So we really just don't have any treatment in the hospital. Out of the hospital, monoclonal antibody can help provide some passive immunity that will last for about 3 months to help reduce your hospital stay. But supportive care really is even in or out of the hospital.
Ivermectin's great if you've got worms.
It's,
I'm not saying it's a bad drug.
Because that's what it's meant for.
It's not exactly. It does
Very
have
helpful.
a role. I'm not saying it's a terrible medication.
there's a lot of really angry horses out there right now.
Just not for COVID. Yeah.
All right, let's talk about, and this is going to be directed at Dr. Sharkey, and of course anybody else can chime in. We've got to talk about vaccines in children ages 5 to 11. I've got an 11-year-old. He's all over the place. He actually wants to get the vaccine. I think he understands it because his brothers have it. But what's the real question? This FDA comes and approves this. What is this going to mean for families with children ages 5 to 11?
It's going to be a game changer. You know, we're finally going to be able to protect these children as they want to desperately go about their ordinary lives. They want to go to school without a mask. They want to go to soccer games, basketball games, have sleepovers. And we have a vaccine that's hopefully going to be approved here in next week. We're hopeful that by the end of the next week we're getting first doses in arms, and it's with 1/3 of the dose. It's 10 micrograms. This is the smallest dose of a vaccine ever, and it's been shown to be just as effective as the 30 microgram dose, which is really exciting. So those 11-year-olds are getting ready to turn 12. If you have a question about do we wait, which dose do we get, you do the smaller dose. It's just as effective, and it has fewer side effects. So that is really, really exciting. We potentially could have a lot of kids fully vaccinated by Christmas and grandparents with their boosters. We could have normal holidays. We could all get together and hug each other. This is very exciting. So I encourage everybody. I know there's going to be a lot of questions that parents have. I encourage you to talk to your pediatrician. I'm a pediatrician, please reach out to me. We want everybody to feel comfortable with it, and there's gonna be people, especially with the older kids, we expect parents of these older kids, the 11-year-olds, actually they're kind of mad. They're like, why can't I just go ahead and get the vaccine? I'm bigger than most 12-year-olds I know. Right. So we expect those children to get vaccinated first. There may be parents with the 5-year-olds that take a little bit of a wait and see approach, and that's fine as long as you understand you got to still do all the measures. You still got to wear the mask and social distance, and maybe not go see grandmother. But it's really exciting that we could be approaching a normal holiday season with these kids, and perhaps go back to school in January without masks.
So even for the parents that may be sitting there, and I'll be perfectly transparent, I kind of thought this way, man, I've gotten this far without it for him. Maybe I could just ride it out because, we'll get to the end of this.
Well, what we are seeing, especially with this Delta variant, it's going to find a host. It's going to find the vulnerable host, and we're seeing a greater percentage of our cases in the unvaccinated children. Disproportionate to the number of kids we are seeing. So it's going to keep, it's going to find a victim, so to speak. So waiting it out is just actually putting that unvaccinated person at greater risk as we keep driving it down.
And people are saying well, kids don't get so sick, it's okay. We've had over 8,000 children who have been hospitalized with this, and several hundred who have died.
I think that's a
from
leftover
COVID.
remnant, kind of like pregnancy as well with the alpha and the original wild type. The Delta variant is just a different ballgame.
Different ball game. And we've had deaths, pediatric deaths in Arkansas. There was over 100,000 pediatric cases last week in the U.S. So it's affecting our children, and they are getting the post-COVID complications. They are having headaches and migraines and brain fog and prolonged loss of taste and smell, which is affecting their ability to eat and therefore grow and thrive, which they're supposed to do. And then also just the loss of education, and the mental health impact. It's just what this virus has done to our children is, we're going to be studying it for decades, unfortunately. But the sooner we can get them back to normal lives, we're going to be able to start addressing those underlying problems that it's caused.
Yeah, and I'm going to ask the audience to indulge us for 5 more minutes as we close this out, because we do want to talk about boosters, Dr. Wood, and I want to find out, why are boosters being recommended, and who are they currently being recommended for?
So one of the things that we've already talked about is how different vaccines and different viruses and infections work in our body. So we have some vaccines, like the Tdap vaccine, where we recommend every 10 years for non-pregnant adults. And then we have other vaccines like the flu vaccine where we recommend getting every year. And part of this has to do with how your body builds antibodies to a particular infection. But part of this also has to do with the presence of a certain type of infection in the community. With COVID, we are still in what we call a pandemic, where the virus is still spreading. It's still infecting a significant number of people. We haven't reached a level of the most close thing that we can think of in terms of endemic is the flu. So where we get the flu vaccine every year because our antibodies wane or decrease to increase our immunity, to improve our ability to fight against it if we do get it, and also to prevent ourselves from getting it in the first place and to spreading it to other people. So with the COVID vaccine, we've seen that sometime around 6 to 9 months after getting the initial doses, that our immunity, those antibodies, starts to wane or starts to decrease. And so we can boost our immunity or increase our body's response to getting the infection by getting a booster shot. And that we've seen that from the data. The booster shots are safe, and they have shown to increase our ability to fight against the infection itself.
And you know, piggybacking on that, for those older adults that may get the booster, would it make sense maybe for them to just get the booster version or of the child level, or does it the size of the vaccination matter?
So some of the data is showing, particularly with the Moderna vaccine, we're giving actually a half dose of the Moderna vaccine for a booster. You can receive the half or the full. It's not showing really any difference in how it affects, just like we were talking about a little bit with the Pfizer vaccine in children. So with the booster, you can get the half or the whole. You can also mix and match in terms of the booster. So say you got 2 Pfizer doses, but your pharmacy down the street only has the Moderna vaccine. You can get the Moderna as your booster. And for, you know, when do I get the booster? Well, 28 days after your initial dose, if you're over 65, if you're immunocompromised. What does that mean? That means you are on a medication that makes your immune system go lower, like chemotherapy, or you have lupus on a medication that lowers your immune system. If you have AIDS or HIV that is active, where your immune system can't fight. So then 28 days after your initial series, you can get another dose. For the rest of the community at large who's at risk, so those with diabetes, those with a BMI over 25, those with asthma, those with a whole host, and that encompasses a very large percentage of our population.
Pregnancy counts as
Yes,
underlying
pregnancy.
condition.
Yes.
So pregnancy is also a qualifier.
So if you look at the list, a huge majority of us qualify for the booster, and 6 months out after your original doses, you can get that booster.
Right. And the mixing and matching is probably going to be
Yeah,
irrelevant
it's safe. We've not seen any negative effects of getting one and then getting the other. And while we don't have all of the data, some of the data suggests that you may have a more potent, robust response if you get the next vaccine, a different booster than the original series that you had. But at the same time, we are allowing more convenience as well. So if you only have access to one or the other, then you can get that. The Johnson & Johnson vaccine is another one that people have questions about. And for those who are in that high risk category, and talk to your doctor, look at the CDC about whether you qualify. 2 months, after the first dose of the Johnson & Johnson vaccine, you can get a booster dose of the Johnson & Johnson as well.
Okay, all right. We appreciate that. Well, this is a quick speed round because I'm going to go to each one of you, and I want you to answer this question for me. I'll start with you, Dr. Deschamps. What are your predictions for COVID-19 1 year from today in Northwest Arkansas, since we're regionally focused? And is this going to be a situation where we'll permanently deal with the COVID or some level, or do you believe it will go away entirely?
Yeah, I don't think that it will go away entirely. I think everyone may agree with me on that. How often are we going to be? Is it going to turn into a flu type of a situation? That'll be determined on how much vaccine rates go up. The more we're vaccinated, the less chance this virus has to mutate. you know, every time it infects you, it's got a million chances to make a new version of itself. And so I feel for the first time, I think I told my wife this the other day, that I feel hopeful because I'm starting to see the rates going up significantly. Enough people are starting to, I think, have good information, have experiences with friends or family members with either the vaccine or having a bad outcome with COVID, that people are really starting to be like, it's okay, it's been a year, we've seen this vaccine, I'm going to get the vaccine. And that will really shut things down quite a bit. So in a year from now, I think it'll be a lot better. But I don't think that we're ever going to be able to forget about COVID.
Yeah.
It's not going to be in our past for, I don't know if that's ever going to happen.
Yeah. Dr. Ricklin, your
I'm an
prognosis?
optimist by nature. I think we're definitely a light at the end of the tunnel, and we're going to be at a better place next year.
Mhm.
But I agree with Dr. Deschamps. I think we're still going to be feeling some of the effects of the COVID-19, particularly, especially, and we've seen this recently in terms of chronic conditions as well.
Sure.
And I think one of the key points that we were talking about earlier, as far as somebody with COVID under quarantine, staying hydrated at home, monotherapy is an option, is make sure that they also control their chronic conditions and take their medications as well.
Absolutely. Dr. Sharkey?
I agree. I think that unfortunately that COVID is here to stay. It's going to become endemic. And I think that we're all going to need to think about masks kind of like an umbrella. You aren't going to need one all the time,
Right.
but there's going to be times and places that you're going to need one. So we just need to change our thinking about, oh, masks are gone forever, COVID's gone forever. That's probably not going to happen. For me personally, I'm never getting on a plane again without a mask because I don't want to ruin a vacation by getting sick.
Right, exactly. Yes, sir.
Yeah, I agree. I'm kind of an optimist myself, and so as I see numbers going down throughout this whole pandemic, I've been like, "Is it over now?" Because that's what we're doing in the hospital. But I let other people kind of make the predictions. I'm not an epidemiologist by any means. I will say, before we had specific COVID tests, we had what was called a biofire, where you would swab a patient, it would send for an entire respiratory panel, and that was the only way you could test for COVID-19. In February of last year, when we were doing that, or the year before last, we saw a few cases of 2009 H1N1. And so these pandemic level viruses don't go away.
Yeah.
But my prayer, my hope is that it becomes more of a that type situation where you see someone come in the hospital and you're like, oh gosh, that imaging looks like COVID. This may be, we reached that point. If it's next year, if it's next month, that'd be even better. But
Absolutely.
hopefully soon.
Yes, sir.
Yeah, I think if we can get it, we're not going to be able to sit this one out. I mean, you got to get in the game. If you're non-immune, COVID's going to put you in the game. And so if we can get everybody in the game, it'll be epidemic swaths of COVID throughout the world, like we see with flu. When we have our flu, Australia looks at us, and then they make their vaccine, and kind of vice versa. I think it'll be like that with COVID-19, and it'll be epidemic, maybe some seasonal boosters with variants. But if we're still Delta variant, guys, last year's COVID, you would spread to 2.5 people. That's crazy contagious. Delta, you'll spread to 7 people. There's agents of bioterrorism that aren't that effective. So if you're non-immune, you are going to get affected by this virus in some form or fashion. And as RNA viruses rage unchecked through the world, they will make variants, and there will inevitably be a new immune evasive variant. And so we could still be pandemic next year. If we get everybody to play ball and do what needs to be done, it'll be, I think, epidemic portions of the world.
Okay. Dr. Wood?
I'd say the power is with the community to decide that. I could make all the predictions that I want, but it's up to me and it's up to you to make that decision, to put on those layers of protection to decrease that spread, getting vaccinated and wearing your masks in those settings, because we can choose now. We didn't choose in the early parts of the pandemic to make that change, and so unlike SARS and several other viruses that did not become endemic because of the public health measures, we didn't take those public health measures initially, and now we have the opportunity to. We have safe vaccines, and we have all of the public health measures in place and all the data in place to show this is what we can do to stop this from continuing to be a pandemic next year.
Thank you so much. On behalf of Northwest Arkansas Council and the Onward Ozarks program, I want to thank you Dr. Michael Bolding, Dr. David Deschamps, Dr. Marty Sharkey, Dr. Sheldon Ricklin, Dr. Amanda Wood, and Dr. Dan Young for just sharing your expertise with us today and kind of peeling back the curtain to reveal to us what you guys are going on and dealing with on a daily basis. I can't even imagine, and you're going to get back and be confronted with it as you leave this room this morning. There's so many people that are watching this that have never quite experienced COVID the way that you have, but it doesn't mean that it doesn't exist. And I want to encourage everyone that took time out to watch this today to think long and hard about where you are, where you want your family to be a year from now. And I think as a community, we all can agree that we want to come together and be a healthier community. So with that said, please consider getting the vaccine, doing it for yourself, if nothing else, doing it for your elderly neighbor down the street, doing it for that child that looks at you every morning when you wake up. Consider it, because it will go a long way in us fighting COVID-19 and overcoming it. I'm Randy Wilburn, the host of the Northwest Arkansas Council Onward Ozarks program. We thank you for joining us for this regional event, and we look forward to seeing you in the near future. Have a great day.